So good afternoon or morning, depending on which part of the country you're in, everyone. My name is O'Neill Bhattacharya. I'm the co-chair of the Canadian Primary Care Research Network, and welcome to our learning series on integration of care, helping patients move through health systems. So I think any of you who either have experienced healthcare or work in the health system recognize that health systems have traditionally not been particularly easy to move through. There's a mix of the fact that the system is designed to be services are easy to deliver, but not necessarily easy to access. The fact that they're often designed by people who deliver care and don't seek care. And the engagement of patients in the design of systems is a new thing. And it's definitely something within the Canadian Primary Care Research Network that we really want to raise and engage. And so I will say in the Canadian health system where access has been a challenge historically, it's almost like a way of managing demand. And that making systems with high friction and systems that are hard to navigate is almost like a way of rationing or managing access. But it's an irrational way to do it. Essentially what happens is that the most persistent and educated people are the ones who can get through and navigate, as opposed to the ones who need it most. So today we have two amazing speakers who are going to help us talk about care navigation and accompanying people in their care journey as an important strategy to improve health systems and to integrate. So our first speaker is Shelley Doucette. She is the Jaroslawski Chair in Interprofessional Patient-Centered Care, Professor in Nursing and Health Sciences, and Director for the Center for Research in Integrated Care at the University of New Brunswick. She works on interprofessional patient-centered care, and she'll describe a lot of her expertise. I think one of the important things for here is that she is a founding member of the Canadian Primary Care Research Network and has been with the enterprise through all of its forms over many years and spent several years on our executive. So she's one of really one of the people who's built this network that many of you are part of. Our second speaker is Ghislaine Rouly, and she will talk to us about her journey. She is someone who has experienced the health system in a very profound ways and has extensive knowledge as someone who's tried to navigate through the health system, and in that sense is an expert in how to move around these things. But in addition to being a patient and a patient advisor, she's the co-director of the Canada Research Chair in Partnership with Patients and Communities at the University of Montreal, and a member of the Patient Advisory Council for the Canadian Primary Care Research Network. And again, one of the people who is driving change within our network and a core member of our team. So I'm going to hand off to Shelley to get things going. We're going to have two short presentations and then a Q&A. Save your questions. You can pop them into the Q&A. That helps us sort of tee them up. And we're off. We'll begin. Go ahead, Shelley.
Great. So I think Manuel is adding my slides, I believe. Oh, perfect. All right. Is it in full screen mode for everyone else, or is it? Oh, there we go. Perfect.
Oh, Shelley, if I could just say one last thing before you get going.
Sure.
C'est une session qui va être, il va y avoir des éléments en français ou en anglais. On va accompagner, inviter tout le monde qui se sent plus à l'aise en français de s'exprimer en français. Ghislaine va présenter en anglais. Par contre, elle pourra prendre des questions en français. Puis sentez-vous à l'aise. So I want to create an environment where everyone is comfortable speaking in the language of their choice. And sorry, Shelley, let you take things away.
No, thank you. Okay, I'm very excited to present today about the role of patient navigation in enhancing care integration and helping patients and their caregivers access the services and supports they need. I want to first begin, though, by acknowledging that I'm joining you today from St. John, New Brunswick, which stands on the unsurrendered and unceded traditional Wolastoqey land as established in a series of peace and friendship treaties. Go to the next slide. For the outline of my presentation, I'm going to begin with some background context. discussing what patient navigation is and briefly its history. I'm then going to share the approach we use to develop, implement, and evaluate patient navigation programs. Next, I'll highlight some of the patient navigation research our team is engaged in, and then I'll conclude by sharing some directions for future research. Next slide. So before diving into the topic of patient navigation, O'Neill did this a little bit already, but it's just really important to first understand why these programs are needed and the context from which they've emerged. So I'm sure everyone on this call is aware that health and social care systems in Canada are complex and often difficult to navigate. This is particularly the case for patients who experience fragmented care. And this fragmentation arises from a lack of coordination, not only within our healthcare system, but we also see this across sectors such as social development and community supports. And when these systems fail to integrate, we see that patients face delays, missed care, and poor health outcomes. For vulnerable populations, including low-income individuals, newcomers, rural residents, and those with limited health literacy, we know that these barriers are even greater, with many unsure how to access the care they need or how to overcome the systemic obstacles they face. So patient navigation programs were developed over 30 years ago to address these gaps by offering personalized support and guidance. These programs assist patients in coordinating their care, accessing essential resources, and overcoming barriers. Go to the next slide, please. It's impossible to discuss patient navigation without mentioning Dr. Harold Freeman. Known as the father of patient navigation, he actually launched the first program in 1990 in Harlem, New York, to address the profound impact of poverty and cultural barriers on cancer outcomes. His work targeted underserved communities, particularly low-income individuals and racial minorities, who faced significant challenges in accessing timely diagnosis and treatment. He also pioneered breast cancer navigation, creating a model to reduce disparities for women in need. Next slide. So what is patient navigation? So this refers to a role or program designed to guide patients through complex health and social care systems. Dr. Freeman's work has led to the widespread adoption of this model across North America and internationally as an effective and cost-efficient approach to supporting diverse populations. Although the structure of patient navigation programs can vary, they typically share a number of core features, but the main feature is really that the navigators assist individuals in accessing services and supports that are tailored to their unique needs. They also work to overcome logistical, financial, cultural, or social barriers that could prevent people from accessing care. So this could include things like arranging transportation or connecting patients with financial aid resources. Navigators act as a critical bridge between care providers, ensuring continuity, trying to minimize duplication, and also preventing them from experiencing gaps in care. And finally, they provide education by simplifying things like medical terms or treatment plans and offer emotional support throughout the care journey. So essentially, patient navigation, it represents a model of care that proactively guides and supports individuals, matching their unmet needs to appropriate resources. Next slide. While the concept of patient navigation is broadly recognized, we do know there are inconsistencies in its implementation, as well as overlapping responsibilities with other roles, creating confusion. For example, patient navigators often share tasks with other roles, such as case managers, which can create uncertainty about their unique contributions. Another issue that we often see is that the title patient navigator varies across programs, depending on the healthcare setting and the population being served. For example, they may be called an oncology navigator or a community health worker or a health liaison. Patient navigators can also come from diverse training backgrounds based on the needs of the population they serve. They're typically classified into three areas. So the first are professional navigators. So this would be registered nurses or social workers who bring clinical expertise to the role. Or we see lay navigators. So they're not licensed professionals, but they've undergone specific training in patient navigation. And then there's peer navigators. So that's individuals who have lived experience, and they use that perspective to guide and support others. So this is a model that Ghislaine will share with you following my presentation. The choice of navigator, whether it's a professional, lay, or peer, depends on the program setting and the target population. And the programs often do target very different patient groups. So for example, you may see programs around specific diagnoses. So for instance, cancer or diabetes, or it may be for vulnerable populations like newcomers or rural communities. We even see broad-based navigation for any patient encountering system challenges, regardless of their condition or background. In contrast, we also see very narrowly defined programs, such as those designed to guide patients through single interventions like colonoscopy procedures. This variability in patient navigator titles, backgrounds, and the populations they serve, it really allows programs to adapt to community needs. However, it can result in inconsistencies. And I'll touch on some of these challenges as a little bit later in my presentation, but I just wanted to bring them up now to set the stage to highlight some of the key issues. Okay, on the next slide, I'll now share our approach to developing and implementing and evaluating patient navigation programs. So our team begins by conducting needs assessments to identify gaps and barriers to care, as well as their preferences for navigation interventions. We then perform environmental scans across Canada to learn from existing programs, and we also complement this with scoping reviews, which are reviews of the literature, and we look at the international literature to inform our work. Using a co-design process, we collaborate with a diverse group of partners, and this includes patients, caregivers, researchers, community partners, clinicians, health system managers, and decision makers to co-develop and implement the navigation program. A key pillar of our work is patient-oriented research. Individuals with lived experience are actively engaged throughout the entire research process, and for every project, we establish a patient and family advisory committee. And this is really to ensure that the interventions are relevant and directly address the needs of the people we aim to support. Okay, on the next slide. So as you can see, though, from what I've just mentioned, we do have a very large and dedicated team that supports this work. But I just want to highlight 3 key individuals whose contributions are central to our navigation research. And this is, as you can see on the slide, we have Drs. Luke McNeil, Alison Luke, and Elaine McNeil. All 3 are research associates with the Center for Research in Integrated Care, also known as CRIC, and their expertise and commitment is really integral to the success of the research that I'm sharing with you today. Okay, on the next slide, I'll share an example of a patient navigation program our team developed in 2017 called NaviCare SwanNavi, a bilingual navigation center dedicated to supporting children with complex care needs. So the program's development was informed by several key initiatives, such as a CIHR-funded needs assessment. We did 2 environmental scans, as well as site visits with navigation programs across North America. A key finding from this exploratory assessment was the clear need for navigational support, not only for families, but also members of the care team. Care providers across health, education, and social service sectors reported facing significant barriers in identifying and accessing services for their clients, and that's even with their professional expertise. As a result, our program served a dual purpose. We were there to support children and their families, but also to act as a resource for the care team. So participants were matched with 1 of 2 patient navigators. So it was a registered nurse or a lay navigator who provided both in-person, but mostly navigational services. Based out of the university, the navigators supported clients across New Brunswick. Between the years 2017 and 2020, the program supported 162 families and 42 care providers. We used a mixed methods approach to evaluate the program. And in terms of satisfaction and impact, caregivers noted improved knowledge and access to resources, as well as improvements in their overall quality of life. Our qualitative research captured several powerful caregiver reflections, and this included things like, "She's got my back," made the entire process so much easier. "It was just like talking to an old friend," provided the information that I needed. "It drastically improved my quality of life." "She lifted this huge weight," and finally, "took the emotional anxiety and stress away." A key lesson from this research is that patient navigation works best when it's embedded within the healthcare system, not as a standalone program. Running it through a university, it did provide us with flexibility and support to be innovative, but this also had a complexity by creating another layer for patients to navigate. So integrating navigation into the system also makes it more sustainable. On the next slide, most recently, our team piloted Navigating Dementia NB, a patient navigation program in New Brunswick for people living with dementia, their care partners, and the care team. Much like our last project, this was designed based on a needs assessment, a scoping review of the international literature to really understand how dementia navigation programs are implemented worldwide. And then we also did an environmental scan of dementia navigation programs here in Canada so that we could identify best practices. And this work was carried out with support from Healthcare Excellence Canada. One of the central findings from this exploratory work was the need for navigational support to be embedded within primary care, which also aligns with the earlier research from our last project. We therefore implemented the program in 6 existing primary care settings across the province in both rural and urban settings. We also learned from our exploratory research that there was really a preference for the navigators to be professionals, given the complexity of needs for people with dementia. As a result, we hired navigators with a variety of backgrounds, but mostly nursing and social work. This project ran for 12 months and served 150 participants between 2022 and 2023. And our findings show that patients and their care partners were satisfied with the program, and they reported improvements in things like accessing health and social services, their ability to communicate with their care team, confidence in managing their care, their ability to age in their community, and they also reported reductions in feelings of social isolation and loneliness. For participants who are less satisfied with the program, 2 main issues stood out. Some joined after exhausting all other options, making their challenges especially difficult for navigation to resolve. Others experienced frustration with what we call navigating to nowhere, where despite the support offered, no suitable services or resources were even available. These findings really emphasize the need for early intervention and sufficient system capacity to support navigation efforts. And where this project is wrapped up, we are currently collaborating with government to explore options to sustain this program. On the next slide, you'll see that we've also been recruiting patient navigators from across Canada to explore how ChatGPT, which is an AI chatbot, can enhance patient navigation. So while this study is ongoing, early findings highlight several potential uses, such as patient navigators using it as an information resource, creating step-by-step workflows, and generating scripts or prompts that navigators can use with their clients. Navigators also see ChatGPT as a significant time saver and a helpful tool for patients and caregivers who are looking for information on accessing health services. In a separate study, we're also investigating public interest in using chatbots for patient navigation. While new technologies like this are very exciting, they are only meaningful if people are willing to use them. Based on our findings, people have cautious interest in this technology. There is, however, a particular interest for chatbots that help users locate services, access resources, and coordinate their care. On the next slide, our team has also conducted qualitative research examining the roles of patient navigators across different settings and patient populations, focusing on the rationale for implementing both lay and professional models of patient navigation. And it was really interesting that the findings actually indicated that a patient navigator's personality and their experience, whether that be their personal experiences with the healthcare system or work-related experiences, may be more important than their specific designation as being lay or professional, with strong interpersonal skills being especially important. Next slide. The final piece of research that I'd like to share is our active work on scoping reviews to examine different aspects of patient navigation. We are currently conducting a scoping review on the impact of patient navigation programs. And preliminary findings highlight significant variation in terms of how patient navigation is defined and their scope of practice, which really underscores the need for greater clarity and consistency. Our team has also published scoping reviews focused on patient navigation for specific populations, such as individuals with dementia and trauma patients. And these reviews really provide insights into how navigation can address the unique needs of these groups. Finally, our team conducted a scoping review exploring the roles, functions, and backgrounds of patient navigators and case managers to clarify the roles and responsibilities of these 2 roles across various contexts. So this comprehensive review included 160 articles uncovering both key differences and areas of overlap between the roles. When it comes to patient navigators, the review found that they can be individuals with or without clinical expertise, such as I mentioned before, nurses or those with lived experience. And their main role is really to assist patients in navigating existing health and social care services, but they're really not there to provide direct care when services are not available. Case managers, on the other hand, are typically trained professionals, such as nurses or social workers, with expertise in creating and managing comprehensive care plans. Unlike navigators, they fill gaps in care by directly providing services such as psychosocial support or clinical interventions. And they often work with patients who have complex long-term needs, managing and coordinating all aspects of their care. Both roles provide emotional and informational support to patients. However, only case managers deliver clinical care. This review really highlighted significant ambiguity between these roles, often causing confusion within healthcare teams. And as I've said before, standardized definitions of their scope of practice is really going to be critical to improving role clarity and enhancing service delivery. Next slide. Just a final initiative that I want to share is that our team co-hosts the Canadian Healthcare Navigation Conference in partner with the Family Navigation Project at Sunnybrook Health Sciences Centre in Toronto. The conference provides a platform for sharing best practices in healthcare navigation, as well as for knowledge, translation, and exchange. So for anyone else who's interested in this field, preparations are already underway for our 5th annual virtual conference scheduled to take place in April of 2025. Next slide. So I'll just end off in terms of future directions. Our findings really demonstrate the adaptability of patient navigation programs across diverse populations and settings. As interest and investment in these programs grow, it's really going to be vital to have broader guidance and direction on how and where these programs should be implemented to best benefit patients in health and social care systems. Without careful planning, there is a risk of creating unnecessary, duplicative, or overly specialized patient navigation programs that actually add complexity to the healthcare system and provide little return on investment. We are currently planning a study that aims to address these issues by exploring how patient navigation can be best utilized to improve access to care and achieve the greatest impact. And the outcomes of this study, we're hoping, will guide targeted implementation of patient navigation programs, ensuring that resources directed toward populations with the greatest need. So for anyone else interested in this space, please reach out, because we're always excited to expand our team. Okay, final slide. As I hope you can see, patient navigation programs are designed to ensure that individuals receive the right support at the right time, helping them navigate what can often feel like an overwhelming system. These programs do more than just guide patients. They help break down barriers, they improve access, and create seamless, connected pathways across health and social care systems. The ultimate goal is to ensure that no one is left behind in their healthcare journey. Thank you.
Thank you, Shelley. So we're going to take questions. So save your questions to the end, but you can start writing, typing them in as we go. And then now we're going to hand off to Ghislaine and Izzy.
Well, thank you very much, Shelley. And I think I will join you on April because it's fantastic. I'm really passionate about it. I'm sorry, I don't have any slides, and I will probably, I call it the storytelling of the trajectory of a patient partner turned co-director of a Canada Research Chair. I was born with 2 genetic orphan disorders, survivor of 3 cancer, and almost 6 months of palliative sedation. It took me 2 years of rehabilitation, readaptation to become the person that I am today, more or less. Living with lots of side after effect from all of that. Meantime, I was the sole caregiver to my daughter, who passed away at 20 from cystic fibrosis. For more than 50 years now, I accompany patients, peers, citizens, members of the community suffering from medical situations, along with social problems, including homelessness. For more than 15 years, I became a patient trainer and mentor to students at the Faculty of Medicine at the University of Montreal, and also to clinicians, where I met Dr. Antoine Boivin. Together, we co-founded a participatory research program called the Caring Community, on integration of people with lived experience within primary care teams. I became a full member of the team as caregiver and educator at the University Group of Family Clinicians since 2015. I managed to do my first year of med school, but due to my numerous hospitalizations, I wasn't able to continue. As a result, I don't have any university diploma. Nonetheless, in 2023, thanks to Antoine Boivin, I was the first patient in the country without any diploma to be named co-director of the Canada Research Chair in partnership with patients and community. In our team, we work with different types of peers, as we call ourselves. Our work demands that we work, collaborate, exchange, learn, and support each other. We have Indigenous navigator, migrant navigator, harm reduction navigator, peer helper in mental health, peer mentor, patient partner, and so on. You will have at the end of my presentation 4 slides, including one that describes better all the different approaches and names of navigation, both in French and in English, the results of an article written by my colleague, Andrea Panaite, who is a researcher. In my practice at the clinic, where I work 2 days a week, I do accompany patients in their life trajectory with illness. And I'm really not, as a professional, I don't think myself as a professional. It's just that I really try to be there, accompany them in their trajectory with illness. Very often, a patient, once he became a patient, is losing his own identity and doesn't remember what it was before, or at the opposite, wants to go back what it was before, and it's impossible. But nonetheless, to remember them, to make them remember that they have strength, that they have all they need to do. They always have a choice, not with their illnesses, of course not, but how they will deal with the illness, what they choose to do with it. Are they going to be a victim for the rest of their life, or are they going to take action and make the best of the situation? Clinicians, doctors, psychologists, psychiatrists, nurses, social workers, interns, and residents refer to me patients with mostly psychosocial problems on top of their medical situation. I do not want to have access to the patient's files. It is up to them to share whatever they want with me or not. The clinicians give me a summary of the problem and, importantly, the objective of my implication. It is confidential, in a safe environment, without judgment. What really moves me the most is the rapidity in which trust is built. I am used usually to work at the speed of trust. It is all about relationship. To recognize the other one in its totality, mind, soul, and body. For many people, it is the first time in a very long time that someone's pay really attention and let them speak. And it is as if all of a sudden the dam broke and they let out their most intimate thoughts, memories, pain, traumas, etc. All I can do is to validate and welcome their suffering. The medical part is a pretext that leads to the real discussion. The majority of the patients are extremely vulnerable, isolated, even within their own family sometimes. Some are in the streets. Some are in such precariousness that it is similar to homelessness. Mostly, violence is part of their life. I accompany patients between the age of 25 and 92 years old. We are not paired by age, illness, sex, gender, etc. Only one human being to another. It is a very natural intervention for me. This is something that any human being will do for thousands and thousands of years. This is not new. It is better organized now, and we are recognized, but in a way, it's something that most humans will do. You have an example, you have a snowstorm, and what happened, even if you don't know your neighbor, all of a sudden everybody's helping you. So in times of need, we are there. We realized in our research that for each person I accompany, we save at least $15,000 a year in medical fees. So far, my work saved around more or less $900,000 a year. So it's something that was researched. So it does save, because not only do I accompany them in their trajectory, but I also teach them how to be a better patient, to be a patient partner of their own illness, not to be afraid of asking questions, how to meet, where to go, what to do, what not to do. So it's very much an education at the same time. And very often you realize that they go less and less to emergency because they have a better understanding of the system, because they're not afraid anymore of talking or speaking or asking questions to the doctor. Very often we realize also through this research that the patients are taking much better care of themselves. They do better their treatment. They understand better their medications. So all of this is a plus for the medical. So we're really working together. I wear multiple hats in a week. I'll share with you a little bit how it is to be a peer, but I became a patient researcher, giving lectures like today, writing articles recognized nationally and internationally, for example, by the National Institute of Cancer in Paris, as co-president of their scientific committee, where I will be lecturing on the end of life in December. I am sharing you my story not to talk about me, that's not the subject, but to give hope, to open doors for others like me, that for no fault of their own, they were punished in a way, put aside of the intellectual society by the system for not having any diploma. Don't get me wrong. I am devastated, really, not having one. They are necessary. But sometimes we miss so much by not recognizing the richness that lies in front of us. And unfortunately, I think we are wasting great minds. I was sharing my story with many clinicians. They all congratulate me, but that was it. Until one day in my class at the university was this student, Antoine Boivin, who was attending as an observer, and at the end asked me to join him for a coffee. At that moment, he recognized something that he was looking for many years. We, Antoine and I, in spite of our differences, him as a clinician, young, researcher, brilliant, and myself, a patient, almost at the end of my life trajectory, we recognize ourselves in our values, in our dreams, in risking to meet failures, but not afraid to learn from it. It is all about trust, respect, admiration, humility, and a passion for what we believe in, humanity. In fact, we are complementary. Thank you. I want to say just one more thing, because Shelley talked about Dr. Freeman, and in the 90s, I was living in the States, and I was actually one of the first navigators at the Roswell Institute in Buffalo in cancer. This is how I started all this wonderful story. Thank you, Anil.
Thank you, Ghislaine. You mentioned some slides. I don't know if did you want to share those slides?
I think that Manuela will send them all together to everyone, I think.
Perfect. Okay. So there's a question from Joni, but I just want to take the chair's privilege to ask a first question. I'm going to start with Shelley and then come to Ghislaine. Actually, maybe I'll start with Ghislaine. You know, your presentation made me think about a keynote. So many of you were at the North American Primary Care Research Group meeting in Quebec last week. And our keynote was, the first keynote was Iona Heath. And she talked about the role of the clinician in alleviating suffering. But, she said what you've described just now is a role that's equally, if not more powerful. And given the constraints on our, within our system and the number of people that physicians have to manage, can you tell me a little bit about how you've worked with clinicians in the practice to enhance this alleviation of suffering? And just tell us a little bit about how these roles are complementary.
Well, I think they are truly complementary. If I may take an example, a concrete example. Antoine had a patient. She was 42 years old, really with multiple illnesses. I'm sorry for my English. But anyway. She never came to the office. She always go directly to the emergency. She wasn't taking her medication. Actually, she was like Antoine was saying, the one bad patient. And he was almost giving up, and he said, I don't know what to do. And she's really, really sick. I mean, with her heart, liver, kidneys, and so on. It was really a situation that was drastic. And he was open to go to her house, and she always refuses. So he said, well, do you want to talk to her? I said, yes, I will. She agreed. I explained who I was, a patient, not a professional. And all of a sudden, like I said in my presentation, the dam just broke. And what I learned, I asked her permission to say what's happening to Antoine, and she authorized me to do so. What was going on is this lady was living in a house full of rats, no money to take a cab, no money to have even good food for her diabetes. No, in a situation that, I think honestly, she would have been better outside than in the house. She allowed me to come and visit her. And I was in a position to be able to right away, I call des organismes communautaires to help her out. She allows me to talk to Antoine. And I explained, she didn't want Antoine to come to the house because she was embarrassed. She couldn't come to the office because she didn't have money. She couldn't call to say that she wasn't coming to the appointment because she didn't have a phone, and so on and so forth. So finally, I asked Antoine and I said, look, why don't we work all together? Yourself, the social worker, the psychologist, myself, the nurse. We bring her at the office. I go and pick her up. Her adults, children to come so they understand what's going on with their mother. So we had a huge meeting all together at the clinic. And what happened is that finally, after maybe a few months, I was able to give her a lot of coupons for food, new clothing, help for the rent. The nurse was able to go to her house, not Antoine, because she was still embarrassed because he's a doctor, but the nurse could come and so on. Finally, what happened is that working together, knowing what this woman was going through, all the difficulties that she has, and to explain that to Antoine, what it did is that it turns not only the things around for the lady and her children, but also for Antoine as a doctor, because now he had the real picture of whom he was dealing with. And this lady, it was beautiful because she survived. Unfortunately, she passed away last year, but she survived and she became an extremely good patient partner. I mean, she was sending her glycemie, to Antoine very thoroughly. She wasn't going to the emergency unless she really needed to. She was coming to her appointment. So there's a way, I think, when we speak, when the doctor has the chance to really know who the person in front of him is, and that there's collaboration, this is why partnership is so important. So I don't know if I answer your question, O'Neill, but that's one example.
Absolutely. Thank you, Ghislaine. I think that's a very, very powerful example. I want to take Joni's questions around, the implementation and maybe just frame it a bit for you, Shelley. So what Ghislaine has just shared is a situation where, in fact, the navigator has access to the person in ways that physician cannot. In this example, the physician is too far away to really solve this problem. And so, we're in a healthcare human resource crisis in primary care. Tell us a little bit about how is this an HR solution? These are complementary functions. How well does it work? How well does it scale? And tell us a little about it. You've already built some programs, but you've also studied programs from all over the world.
Yeah, I think it's definitely scalable. And actually, one of my biggest worries, and that's why the project I was talking in the end, it can really be an intervention for any population. So one of the worries is that it becomes too spread, like implemented in too many places. So I think in terms of the question around implementation more widely, I think we need to be cautious not to implement it too widely, such that we actually create a system that is even more challenging to navigate because we have navigators for everything. As I mentioned before, I'm doing that review. Our team's doing a review around the impact of patient navigation, and it's incredible the number of different types of programs that are being implemented. So I think in terms of going forward, in terms of implementation, we need more evidence to really understand when we need a patient navigation program, like an actual program, versus it being part of somebody's role, say within primary care, whether it be the social worker or the registered nurse. So being part of their roles and responsibilities. And so that's why I think the work that we're moving towards next is around really trying to understand. So for which groups really do need these types of programs? And we already know groups like newcomers, cancer, that these are really promising areas that I think experience significant barriers in terms of accessing services and supports. But then there's also opportunities within primary care and other settings to use existing resources to try and help people navigate the supports and services that they need.
Briefly, can you comment on the scale of this in Canada? How widespread is this? And maybe a little bit on how often do these projects become programs?
Yeah, good question. So unfortunately, for the most part, oftentimes these programs are short-lived. They're often pilot programs, or they're oftentimes funded from different community organizations like the Heart and Stroke Foundation or other programs like that. They implement these models. There are some well-established. So we know within cancer care, it's very well-established. And there's other settings as well we're seeing within newcomers and so on. We're starting to see them more established. But one of the problems is it's really difficult to demonstrate the impact of these programs to actually scale and spread more widely, because when you think about it, when we're looking, say, at the return on investment, in the short term, you would actually see an increase in terms of the resource utilization. So the navigators connecting them with more services and support. So it's hard to demonstrate the return on investment because you don't really know you're not really capturing the long-term cost savings over the complications had they've not received those services. And then also, when I was talking about earlier, another barrier in terms of spreading and scale is that it's hard to run a navigation program when there are no services and supports to navigate them to. So that's another barrier in terms of having more widespread programs, because sometimes these programs, the participants are shown to be not satisfied with the programs, when in actuality, it's not the program, it's that there's no services for them to actually be navigated and directed to. But yeah, just going back to your question, though, I would say that the majority of the programs that have been more sustained and embedded within our healthcare system have been more oncology focused. And some of the other areas have mostly more been pilot type programs. We're seeing there's a number of programs as well for mental health and addictions that have been sustained, particularly the one we've worked a lot with, the one in Sunnybrook. So there are other pockets, but yeah, I think there is a lot of work to be done. And I think one of the most important things as well to demonstrate impact is that we need to have more clear definitions in terms of what a patient navigation program is, more consistent definitions, and also scopes of practice for patient navigators so that it's not so confusing for the public and for decision makers and clinicians and healthcare teams to really understand these programs, because I think that's also affecting the spread and scale, is that people just are confused and finding it just another added layer, when I think having that clarity would really help.
May I jump in on it? Here in Quebec, what we have, and it's a peer helper in mental health, and they are really, they have a name, a brand in a way. They are recognized, they are paid, and they are almost everywhere now. So it is really, we don't call them navigator. They're really peer helper, les pères aidants. And it's really mostly, like I say, in mental health. And we have it, in the almost everywhere now. And including right now in France, it's starting to happen there again, also, I mean. So we have different things, and navigation, like, we work a lot with Indigenous groups, and Indigenous navigation is something else also. So we have, I don't know how to say, but we have different groups, at least here in Quebec. And we are trying, I did un cercle d'apprentissage, a learning circle, I think, and where all the peers, we call ourselves peers, from different groups, different type of work that we're doing. And we are meeting every month together to discuss, to exchange, to learn from one another. And also we invite people, medical, des gestionnaires, and so on and so forth, to be aware of what we are doing. It's not, like a little thing where nobody can see what we're doing. Not at all. It's very in the open. But this is something that in Quebec is becoming more and more widely user. Is that how you say?
Yeah, widely used. Yeah. Okay, so Ghislaine, one question for you, and anyone who's got questions, either you can put up your hand, it's not, or put that right into the chat. So during the NAPCRIC conference, I chatted with one of your colleagues, Mathieu Isabelle, who is doing some work on peer helpers in homelessness. And one of the things he mentioned was the idea that the peer helper, because they've experienced homelessness, has more legitimacy, or rather, the fact they're working with a clinic makes the clinic more legitimate.
Yeah.
Makes it, it makes it more, not only accessible, but also more legitimate to the individual. And to what extent does formalizing that role assist or impede that? And does becoming too connected with the health system sometimes impede your function? And maybe just to comment a little bit on your experience with that versus things you've observed from others.
Well, with Mathieu, actually, this is what it was. One of our research. We work with Mathieu, and I'm the one who coached Danielle, the peer helper, and I think that to do this type of work, you have to have a lot of strength mental strength. You have to have a lot of humility to realize that you don't play doctor. You're not a psychologist. You are just yourself. You take your job seriously, but you don't take yourself seriously. There's something in there. And I think that the fact that Daniel, for example, was a homeless, he knew exactly, he goes in the street, outreach, he knows right away what the other person can feel, the anger that he can have, and so on and so forth. And for me, being sick from birth, having going and still going through the system, I know exactly, the way people feel, the way they are lost sometimes, desperate, but my role in a way is to try to give them another view of what they're going through. Instead, I come back to the victim and the acting, but to me, it's very important. I mean, to realize that, okay, you're still here. You still have some power. You can still function somehow. And maybe you can't be the person you were before, but when we grow old, it doesn't matter. We change anyway. So with illness, it's the same. So to give hope. But I think I'm not answering your question, quite frankly. I think I'm.
Yeah, I think you've helped, but let's just take it a little further. Let's take Daniel's example. If he's paid and has a formal role, does
Yes.
that make him more or less legitimate in the eyes of the people that he's trying to help?
Well, first of all, when the people he's helping, they don't know whether he's paid or not. So I don't think it makes a big difference. As long as I do outreach also in the streets. And just to talk to a homelessness person, the fact that you say hi, the fact that you pay attention to this person as a human being, just that in itself is a plus. And you have to remember that Daniel, the beauty of it is that he started as with us as a researcher. After 6 months, Le Sius was so impressed by his work, by what it was doing to the clinic, they offered him a job, a full-time job. So he's truly part of the team. And I don't think that, it makes any difference. If you knew Daniel, he's a very tall young man, very humble, very warm. And at the same time, he is so proud of what he's doing. That for the clinic, it is really a plus for all of them. So I don't know if I answered.
Yeah, that's perfect. I think the point essentially, do you want to jump in there, Justin?
Yeah, I just want to add one thing. So you had asked about how the client receives it. What we found from some of our earlier research when we were looking at the differences between peer or lay navigators compared to professional navigators, those who were peer or lay navigators, they felt that they weren't always respected by the healthcare team. So because they didn't have a professional designation, they felt that they experienced a lot of hurdles and barriers in terms of trying to advocate for their patient because they were not seen as a true member of the team, is what they felt. So again, I think there's the majority of the work, like the research did show the value in lay and peer navigators in terms of embedding them within the healthcare system, but that was a major hurdle that they felt in their role.
And I agree with Shirley. I think that, working with Mathieu or working with Antoine, we are working with two very incredible professionals, and it's not easy. I mean, it is not really easy to be part of the team, but at the same time, it depends also on the way you are with the others. It's always the same thing. You receive what you give. I mean, in a way, and yes, there's always people that will put you down because you don't have a diploma, you don't have a title, I understand that. I went through that all my life. But at the same time, we have to grow out of that. We have to say, okay, I believe in what I'm doing. I know who I am. And let's do this. For the one who don't understand, that's their problem. For me, I continue and I will try my best. And this is what happened with Danielle. And I think, I use a lot the word humility, but we need that. If we want truly to be part of a team, we have to be humble about who we are.
Thank you, Gisèle. All right, Gail, go ahead.
Hi, I this conversation because it's hitting smack on some of the tension that I've experienced here in Manitoba. So I had the pleasure of meeting Guylaine a few years ago around developing a peer support worker role, among other things, for individuals who are discharged from hospital and are experiencing homelessness. And one of the tensions that we came across is the idea of legitimacy, not among the individuals who would be receiving or participating with a peer support worker, but on the health professional side, stating that this peer support worker, what kind of credentials does he have? What kind of qualifications does he have? Which makes me think that in the professional world, we're expecting a peer navigator or somebody that's got that employed role, that expertise, and maybe credential. But among the individuals who were receiving that care, somebody who had the same or similar lived experience was what they prioritized. And there was the tension. Now, it seems like that falls right between what both of you have presented today, which is so interesting. But could you comment on that, and how do we see our way past that point?
I can go first, and I think again it's supported by our research. This was already mentioned. It's just so important for when you're hiring the navigator, whether it be a peer or professional, is to make sure that they have very, very strong interpersonal skills, are strong advocates, so that because we know they're going to experience these barriers in terms of working, especially if it's a layer peer navigator, working with the care team. So if there's again strong interpersonally, strong advocates. In the research that we did, they found that it was easier for them to be embedded within the healthcare team. So even when I look at anecdotally some of the programs we've run, it's most successful when it's the individual, it's the personality and the lived experience of the navigator that will make the program successful and will also make the team trust them. And just like any professional, right? Like whether you're a nurse or any professional, it's how you interact with the team, how you connect with them, those interpersonal skills. So I think when you're hiring any type of navigator is to really do that due diligence and making sure that they have all of those qualities and skills, and that will make them much more successful in terms of working with the team. Yeah.
Gisèle, anything you want to add?
Yeah, I think this is exactly that. I mean, it's the way we are, the way we can deal. So are we a person that be able to be working in a team? Are we a team player really? Do we have the respect? I remember when I started at the clinic, at first, it was really, everyone was afraid of me. And seriously, because, and I understand, it is a very dangerous, I think, work that we're doing. If you don't recruit the right person, it can be catastrophic for the team, but for the patients. And it's not enough to have lived something. It's not enough. There's a ton of things that goes behind that. There's a knowledge, there's a presence, there's a I don't know how to explain. I think Shirley explained it so much better. But it's a whole, and it's not everyone that can do that. To me, it's very important to say that it's not for everybody. It's not because you have a little experience that you can do that. It's not. It's a whole. I'm
That
sorry.
speaks volumes, Guylaine, really, because You said moving at the speed of trust. I know that's a bit of a
Yes.
mantra that you've used, and I think it's not just trust with the individuals who are receiving the care or the counseling, whatever you want to call it, from peer support workers. What I think our study learned is that trust also needs to be built among the healthcare
Yes.
professionals. And that's
Absolutely.
maybe something we overlooked. So anyways, thank you very much, both of you.
All right, thank you. We're at time. If you can stay on for a second longer, we can let Michelle ask her question. But for the rest of you who've got other things to go on to, thank you for joining us. And we look forward to seeing our next session will be in the new year. And thank you very much. Michelle, if Ghislaine and Shelley, if you don't have to, if you can stick around for a second, we can let Michelle ask her question.
Great. Is that okay? I don't want to
Yeah.
keep you if you have to go. Thank you.
Go ahead.
Okay. Thanks for your presentation. I had a question about the patient perspective as well in the longer term. So it seems like you're helping some people with pretty complex social needs that are getting in the way of people getting their best results from their healthcare, and they're also benefiting and learning from the navigators' work. So is that something that you see happening where the patients may get more skilled and confident in navigating for themselves going forward? Is that an outcome you're interested in looking at or have looked at?
Yeah, I'll
If
just
I-
say quickly, that was one of the findings from our last project, is that they were more confident in terms of managing their own care, and it increases their knowledge and of all the services and supports available. But yeah, around that self-management piece, that did come out in our last dementia navigation project. That was for caregivers, from the caregiver perspective. Yeah, where it was people with dementia. Yeah.
Yeah,
Thanks.
and for us, the patients were becoming better. They were becoming patient partner to their own health. They knew how to deal with the doctor, the system much better after all this.
All right. Thank you for the question, Michelle. And thank you to Ghislaine and Shelley for sharing your expertise, your experiences, and really moving this topic forward. It was excellent. And I wish the rest of you all a wonderful day.
Thanks, everyone.
Thanks,
Bye.
everyone. Thank you, Neil.
Ok, ça fait plaisir. Au revoir.
Au revoir.